Essential Safety Requirements ESR. By the end of this presentation, the attendees will be familiar with the ESR, International Patient Safety Goals, blood transfusion process, medication error reporting, needle break and body fluid exposure, and other related ESR standards. What we mean by the ESR? Essential Safety Requirements is a SIPAHI standard. When applied, it can ensure the safety, meaning no harm of the patient and healthcare workers. There are 20 ESR standards, and it is, as its name, it's essential for accreditation. In the SIPAHI booklet, you will find the ESR standard highlighted on the left under the number of the standard. First goal of the International Patient Safety Goals is to identify patient correctly. So when do we need to identify the patient? Before administering any medication, before administering any blood or blood product, we need to identify the patient. Before taking a specimen, regardless of the specimen type, before providing any treatment to the patient, and before any procedure, even simple procedures as obtaining the blood glucose through the HGT or the RBS, random blood sugar checking using the glucometers. How to identify the patient correctly? We need two identifiers, MRN and full name. In some cases, the name of the patient will be identical with another patient, like the three names of the patient are the same, so that one of the identifiers as full name cannot be used. So we're gonna use the MRN number and the national ID number. In case we have unknown patients, the unknown patient will be numbers as unknown number 1 and unknown number 2, and using a different MRN number to identify them. The correct way to identify a patient is to ask the patient to state his or her name and to check with the name in the file, not to tell the patient the name and wait for their confirmation. The second goal of the International Patient Safety Goals is to improve effective communication, and in case of verbal and telephone order, there are some items that are not acceptable for verbal and telephone order. For example, narcotics. Any type of narcotics is prohibited to be administered through a verbal or telephone order. Total parenteral nutrition, don't resuscitate order are not allowed to be activated through verbal or telephone order. Restraint of the patient unless it's in case of emergency. A muscle relaxant cannot be accepted through a verbal or telephone order. And any procedure that requires and informs consent. For example, patient for lumbar puncture, which is a procedure requiring informed consent, there should be a written order before going with the procedure. So a verbal and telephone order cannot be accepted for such case. And any verbal or telephone order must be validated within 24 hours. There is a verification method for verbal and telephone and panic value reporting. Regarding the panic value reporting, we need two registered nurses to attend the call, and the verification method is by writing down the information that received by lab technician or radiology technician in a box specified for this procedure, and the box should be always kept near the telephone. So what do we need to write down upon receiving the telephone order is what we will see in this page: the date and time, the name of the patient, the file number, the panic value, test and result, the technician name who reported the result and who received the call, and if the verification was done or not. Then after receiving the call, the physician must be informed with the 15 minutes and will write the time informed. So the procedure goes: writing down the information, then reading it back to the lab technician and waiting for their confirmation. The third goal of international patient safety goals is to improve the safety of high alert medication. To improve the safety of high alert medication, we need to understand the meaning of high alert medication, which are a group of medication that has a high percentage of error or sentinel events, and they carry a high risk for adverse outcome. There are some precautions that we must use when handling a high alert medication. First is double lock. Double lock cabinet are necessarily for a high alert medication, especially or it's necessarily for the narcotic medication. For other high alert medication, they must be kept in a lock cabinet or a lock ref if they need to be kept in the ref. Then a double check, independent double check upon preparation by two nurses independently. That means one nurse will prepare and check, then the other nurse also will double check. And the double sign is necessarily in the medication sheet. That's meaning the two nurses, one administered and the other as a witness. And the label for the high alert medication is red label. And examples of high alert medication include insulin, heparin, narcotic and controlled drugs. There is a list of high alert medication provided in every medication room in the hospital, as well as it's available in the shared file. The second group of medication is LASA, or look-alike sound-alike medication. The meaning of look-alike, that this medication have the similar physical appearance or packaging. Meaning, by looking at these two medication, you will find they look alike, or they have the same appearance. Sound alike, that means this medication are similar names in pronunciation. For example, like atropine and atropine. When you hear them first time, you may get confused what's the name of the medication. And to avoid the confusion with lesser medication, there are some techniques we can use. First is the physical separation. The meaning of physical separation: this medication cannot be kept near each other in the cabinet. They must be kept apart from each other, and they must be kept in different shelf. There is another technique we can use about labeling this medication. Is called tall man lettering. The unique letters in the name of the medication can be used as capital letter. And the label for this list of medications, green label. Again, the list of this medication also available in the every medication room, and it's available in the pharmacy shared file. The third group of medication are concentrated electrolytes. And to avoid the confusion of the concentrated electrolyte, orange label should be used, and they must be diluted before use. The list of the concentrated electrolyte medication is also kept in the medication room as well as in the pharmacy shared file. An example is like potassium chloride, magnesium sulfate. And in order to know what is the suitable diluent for this medications and what is the ideal concentration, you can access the pharmacy shared file, then go to the adult, neonatal and pediatric IV manual. Also, the formulary of of the hospital can be also accessed through the pharmacy shared file. In case of any medication error, there is a certain way to report. There are 4 types of medication error. Prescribing error. It's upon the prescription of the physician of the medication there can be error. For example, a different route or a different frequency is used. Upon dispensing of the medication from the pharmacy also there can be error. A different medication is given or a different dose. For nurses, upon preparation or administration of the medication, error also can be happen, like using a different diluent, giving the medication to another patient. This is all considered as medication error. Any one of this medication error has to be reported within 24 hours using this link, provided link, or there is a QR code provided by the pharmacy and is kept on the board in the units. There are some terms like near miss. The meaning of near miss, that's the mistake or the error did not happen but it almost happened. So it's any process variation that did not affect an outcome, did not reach the patient, but for which recurrence carries a significant chance of a serious adverse outcome. If the error reached the patient, what should we do? First is to inform physician immediately, then to apply close observation, and of course to report the medication error. To avoid medication error, there is a 10 right medication. By following it, we reduce the chances of medication error. First, to make sure this is the right patient and this is the right medication, the right dose, the right route, and the right time. After getting the medication is to document it rightly and to also educate the patient. Always remember the patient has the right to refuse. Prior to the medication administration, we should obtain a right assessment, and after giving the medication, we should see a right evaluation. For example, insulin. Before giving the insulin to the patient, we need to check their RPS. Then after that, we need also to check the RPS to see the effect of the medication. The fourth goal of the International Patient Safety Goal is to ensure the correct site, correct procedure, correct patient surgery. And the main point under this goal is the site marking. The site marking must be done by the surgeon at the bedside of the patient, using the mark as a tick and using a purple permanent marker. There are 3 procedures done under this goal. Upon sending the patient to the operation theater, signing in. In the signing in phase, we must verify the site marking, check the allergy status of the patient, the antibiotic if the patient received any, and if the patient requiring any blood or received any blood should be also endorsed, and the status of the informed consent and any related diagnostic result. The second phase is the timeout, which is must be done before the starting the incision on the patient, is to check the team present, also identify the patient to ensure this is the correct site and this is the correct procedure and this is the correct patient. After completion of the OR will come the sign out phase, is when the nurse will take back the patient from the OR. There, the confirmation of the procedure performed should be done. The instrument, sponge, and needle count must be performed, or must be known, and must be checked, and it has to be the same pre and post. The specimen labeling, if there is any specimen, and if there is any specific post-operative concern, should be clarified. The fifth goal of the International Patient Safety Goals is to reduce the risk of healthcare associated infections. We'll speak first about the standard precautions. Standard precautions are measures designed to reduce the risk of transmission of infection from blood, all body fluid, secretions and excretions, non-intact skin, and mucous membrane. The first and most important and most effective way to ensure or to maintain an infection prevention and control in our hospital is to do hand hygiene, and we'll see in coming slides when to do it and how to do it. Then to use the personal protective equipment, handling and disposal of contaminated items. All items should be kept in black waste container unless the patient is having a highly infected diseases such as BTB, or the items was completely or soiled by blood or body fluids. If the items are related to a patient with highly infectious disease, just as BTB, or it's a soiled item, it should be kept in yellow container. The sharp container, without recapping them, without putting back the cover of the needle, should be kept in sharp container. And any body tissues or body organs must be kept in red bag. Laboratory specimen, the handling of laboratory specimen, it must be in a blood or lab box, laboratory box. It should be kept in a plastic ziplock, well secured, and it must not be handled by direct contact, meaning you must use a lab box and must use plastic ziplock bag. The room cleaning and the patient placement. Isolated patient must be kept in isolation room, and any patient under airborne precaution must be kept in negative pressure room. The cough etiquette, by educating ourselves and patients to use the cough etiquette like coughing in our elbows. Food and drink at working station are prohibited except for bottled water, and it must be labeled with the owner name. And by ensuring a safe injection practice, like I said earlier, is not to recap a needle. This is the 5 moments of hand hygiene. Before touching any patient and before doing a clean and aseptic procedure, we must perform the hand hygiene. And after exposure to body fluid, or after touching the patient, or after touching the patient's surroundings, also hand hygiene must be performed. How to do hand hygiene? We have two types of hand hygiene: hand wash and hand rub. The technique as shown is almost the same, with some difference. First difference is regarding the timing. The hand washing require more time, so it is 40 to 60 second time, while the hand rub will require about 20 to 30 second. And we always should allow time to our hands to dry. The personal protective equipment has a unique way to put on and to remove. So how to put on the PPE is first by cleaning our hands or performing hand hygiene. Then we'll wear the gown, followed by the mask and the eye protection, then finally putting on the gloves. Since the gloves was the last thing to put on, it will be the first thing to take off. So we'll take off the gloves first, then we'll perform hand hygiene, then we'll remove the eye protection and the gown, then again we'll do a hand hygiene, then lastly we'll remove the mask, and it has to be outside the patient room. Then we'll do the hand hygiene. There are a different precautions or transmission based precautions. First, the contact precautions. That means that microorganism can be spread through contact. So to avoid the spread of this infection, we have to do the following. First is, and most, as I said, most important is to do hand hygiene. Then wearing the isolation gown and gloves. Then upon before exiting the patient room, we'll remove the gown and gloves and discard as a medical waste. Then we'll perform hand hygiene. Examples of this precautions is MRSA, or multi-drug resistant organism, VRE and RSV. Then we have the second transmission based precaution is airborne precautions. Before entering the patient room, we must do a hand hygiene, and we must also wear N95 mask. The N95 mask must have a fit test. We must do a fit test for the N95, and it must be done every year. Every year we must do our N95 fit test. And before exiting the patient room, we must remove all the PPE except the N95, do a hand hygiene, and remove the N95 outside the patient room. Then again perform a hand hygiene. Example of this disease is like pulmonary TB, measles, and chickenpox. The last transmission based precaution is droplet precautions. That's meaning the organism can be transmitted from a patient to another, or from a patient to healthcare workers through a droplet. Upon entering the patient room, we must do a hand hygiene and wear a surgical mask. And before exiting the patient room, the surgical mask must be removed and the hand hygiene must be performed. Example of this disease is like pneumonia, influenza, whooping cough, and bacterial meningitis. In case of needle prick or body fluid exposure, you must wash the site for 10 or 15 minutes. Inform the nursing supervisor and infection control personnel. Go to the employee clinic on working days or to the ER on holidays and weekend or after clinic hours. Then follow up with the employee clinic. Every needle prick or body fluid exposure must be reported using a specific form that you can obtain from the infection control personnel. The last goal of the International Patient Safety Goals is to reduce the risk of patient harm resulting from falls. And to do so, we need to first is to do a fall risk assessment and reassessment using a Morse scale that we'll see in the coming slide. Once the patient is identified as a high-risk patient, a sign must be put on the patient room and as ID band on the patient hand, and preventive measures must take place. First is patient orientation. A patient must be oriented to their own limits and to the unit structure. The bed of the patient must be low level, dry floor, adequate lighting, the use of a grab bar. The call system must be in reach, and to leave the door open of the room unless contraindicated, like in case of isolation, and to report any incidents using the OVR. This is the Morse scale. It's in the initial assessment and it has 6 categories. Based on the parameters of the patient, he will get scored. If the score is more than 55, the patient considered as high risk and the preventive measure must be applied. Blood transfusion process. To start blood transfusion, there must be a written order. As we mentioned earlier, the blood transfusion is a procedure requiring an informed consent, so a verbal and telephone order cannot be accepted. So a written order must be in the patient file and the request must be obtained. It is the responsibility of the physician to obtain an informed consent from the patient. Nurses can sign as a witness, and any other related consent. All forms also should be, it's the responsibility of the physician to obtain from the patient. Sampling. Prior to sending a sample to the lab to do a cross-matching, 2 nurses need to identify the patient and label the specimen at the bedside. Then a specimen can be sent with the blood transfusion request form to the lab to do a cross-matching. Once the cross-matching is done and it's time to collect the blood from the blood bank, the blood monitoring form must be filled, and all details on the blood unit must be checked in the blood bank section, including the expiry date of the blood product, the unit number, and the blood group, as well as the sealing of the blood unit itself, if it's well sealed or not, and the component of the blood unit also need to be checked. Before initiation of transfusion, 2 nurses in the unit or a nurse and a physician must check the unit again, the unit number, the blood grouping, and the expiry date on the unit, as well as the whole packaging of the unit. And while initiating the transfusion, The first 15 minutes must go slowly to see if there is any blood transfusion reaction, and the vital signs must be obtained prior, after 5 minutes, after 15 minutes, after 30 minutes, and then hourly. If any sign and symptoms of blood transfusion reaction occurred, like itching, hives, complaining of low back pain, tachycardia, irritability, hyper or hypotension, the blood transfusion must be stopped immediately. A physician must be informed, and the normal saline also can be used as KVO. Then, upon the instruction of the physician must be done if there is any medication need to be given, and blood transfusion reaction form should be filled and sent to the blood bank section. Sometimes they will ask for blood specimen as well as urine specimen. A monitoring form should be filled completely without leaving any blank points. Then finalizing on the blood transfusion and on the patient as well. The blood unit bag should be returned back to the blood bank. We have 7 forms for the blood transfusion policy. We'll go through them. First is the blood transfusion request form on the left, and it must be filled completely. Then on the right is consent for blood and blood component transfusion, and this must be filled and obtained by the physician. Nurses can sign as witness. In case the patient cannot give a consent and there is no relative nearby to give the consent, then a physician consent for unconscious patient with no attendees can be filled by the physician. The third form is the education form. And the fourth term is the blood donation form. Before sending any blood request, also donation form must be given to the relative, and to instruct the relative is to donate as soon as possible to maintain a good level in the blood bank of blood components. Then this is the blood transfusion monitoring form. It's totally responsibility of the nurses to fill up the form, and as I said, that the vital signs must be checked after 5 minutes, 15 minutes, 30 minutes, and hourly. And 2 nurses needed upon to identify the patient and to check the unit, that is the correct unit also before giving to the patient. If there is any transfusion reaction, there is a post-transfusion reaction investigation and CABA form. This form is 2 pages, and all these forms are available in the shared file of the lab section. The 7th form, which is not in this presentation, is the tracking or the summary of blood and blood product transfusions, and it must be kept in the patient file. VTE prevention. All patients admitted to our hospital must have a VTE prevention, except if they are under the age of 16. And to do so, we need to do a risk assessment using the VTE prevention and risk assessment. Then based on the risk assessment, which is done by the physicians, a prophylaxis will be suggested, and it's our job as nurses to give this prophylaxis either mechanical or pharmacologically, and the reassessment upon any changing in the client condition must be done. This is the form. It's adult inpatient deep vein thrombosis or DVT screening and prophylaxis. A BMI or body mass index must be obtained to do the risk assessment, and based on the risk assessment done by the physician, the prophylaxis will be given accordingly. For the FMS part, we have 10 codes in our hospital, starting by code blue, which is cardiac arrest for adult patient, code pink, which is for infant abduction, code green for child cardiac arrest, code red for internal disaster, code orange for hazardous material spill, code yellow for external disaster, code trauma for massive casualty, code white for bomb threat or terrorist attack, code gray or Mr. Strong for aggressive person, and code clear for event finished. And the number to call to activate the code is 2800. In case of internal disaster or fire, we must apply RACE and BAS. RACE stands for rescue, and we must rescue the patient nearest to the fire, then the ambulatory patient, then wheelchair patient, then bedridden patient. Then alarm, we must announce with high voice is code red, call 2800 and announce code red, and using the fire alarm in the units. Then contain, we can contain by evacuating patient and working personnel. Also, don't forget always to check the toilet, unplug the electrical machines, stop the DC, close the window. If we have any oxygen tank, must be removed, and close the door and put a sign from outside that this room has been checked and evacuated. Lastly is to use the extinguish or to exit. In order to use the extinguisher, we'll go through a pass, which is to build the pin first, then to aim the fire extinguisher at the base of the fire, then to squeeze the handle, then to sweep from a side to side. In case of fire, the oxygen valve, which is presented in every unit in our hospital, must be shut off, and it's the responsibility of the charge nurse to shut off. So to close it, you must rotate clockwise, that's meaning left right, and to open it you must rotate counter the clockwise, that's mean right to left. We have some other related ESR standard. The patient has the right to go out on bus. That means a permission of the inpatient to go out of the hospital for a maximum of 6 hours. And the self-administered medication can be given to the patient. If the patient must give, there is a form must be filled by the physician and signed by the patient. If the patient did not come within 6 hours, they should be considered as a absconded patient. The bar level, which is the minimum number of items supposed to be available on the shelf before automatic refill. A shelf level is consumable items to be available for general use of the area. We have two critical levels, which are the amount of stock used by the unit in the need to refill, 50 and 20% and 25%. An example, if a unit have a shelf level of 100 underbeds, any number less than this should be filled automatically on the weekly request. If the level reached 50, then an urgent request must be done. If the level reached critical level of 25 and we must inform our superiors as it is a critical level. After this ESR orientation, there is a link for the exam you must complete to get your certificate. Thank you for listening.